Welcome, everyone. I'm Cynthia Rohr, she and her. I'm on Ohlone Land in Oakland, California, and I'm the program director for EDSP at Bridge. I'm so excited to see you all joining us and more folks trickling in. We are here to, we can go ahead, Paco, if you would, and start with the slides. We're here to support funded hospitals in a successful kickoff for the Emergency Department Syphilis, HIV, and Hepatitis C virus screening program, or EDSP. On the next slide, you'll see that EDSP is a result of the California Department of Public Health, and in particular, the STD Control Branch and Office of AIDS, partnering with us at the Public Health Institute's Bridge program. We are here to welcome and celebrate you, and also to connect. So for those who haven't already, please introduce yourself in the chat. We invite you to introduce your name, pronouns, title and role, and hospital name. I'll give folks a moment to do that. And as you introduce yourself in the chat, I really want everyone to join me in giving an enormous congratulations to each and every one of you as part of your EDSP team and part of the cohort selected for this highly competitive funding opportunity. As we see folks' names enter, I want to invite you to take a moment and witness who is here together at this first step in our 2.5 years together. So part of what came before and what will come after for each of you, and maybe notice the familiar and new names as they scroll by. Really excited to see you all here with us. I invite you also to give a particular uplift and shout out to the clinical champions and navigators on the call. These folks are the center and heart of EDSP. They will lead and form your hospital's routine opt-out screening program. All right, let's take a look at today's agenda. So exciting to see all your names entering the field here. For today's agenda, we will introduce the collaborative EDSP team at Bridge. And then we're lucky to have Dr. Kathleen Jacobson, Chief of the STD Control Branch at the California Department of Public Health, who with her team will orient us with a welcome and remarks on EDSP's background. We'll then get to know more about your cohort with an awardee overview, and we'll overview the program itself. So we want you to leave today with a refresher on EDSP's goals, with what to expect on technical assistance, data, contracts, and reporting. And then we'll spend some time brainstorming together. We'll talk about building your team and highlight some next steps. So I just want to mention, if anything that's on your mind is not listed, please know we will close out by reviewing how to reach us, how to ask questions, how to request technical assistance and other support along the way. So let's meet the team. I'm really excited to introduce you to the core EDSP team that will support you all in your programs. As I said, I'm the EDSP program director, Cynthia Rohr. I come with many years of experience in safety net and community clinic, both direct care and leadership. And my work centers around sexual and reproductive health care with a focus on LGBTQIA2S community thriving. And I joined Bridge really excited to support EDSP. Many of you may know one of Bridge's founders, Dr. Andrew Herring. He is an attending emergency physician and associate director of research at Highland Hospital in the Alameda health system here in Oakland, as well as medical director of the hospital's substance use disorder treatment program, and attending physician in its interdisciplinary pain medicine program. Dr. Herring is our EDSP PI and clinical lead, and you can expect to see him attend community of practice whenever possible. So I'll now pass on to LaToya Mitchell, whom you may know already as part of California Bridge. She is our California Bridge Navigator Project Manager, and we're lucky enough to have LaToya support EDSP sites and their patient navigators.
Yes, I'm very excited to be able to really get into more of this grant project. I come with 10 years of experience in the field of opioid use disorder treatment and many of those efforts. And I worked very closely with the Linkage to Care Navigator at Baker's Memorial when I was a navigator there. So I'm really familiar with the nitty-gritty details of getting this program implemented. So I look forward to being able to support all of these sites. It's really exciting. And I'm going to go ahead and pass off to Francesca.
Thanks, LaToya. Hi, everyone. My name is Francesca Chiquin, and I'm a project manager here at Bridge, and specifically supporting the EDSP project. I've been at Bridge for 3 years and previously was supporting the Bridge Navigator program. So I recognize a lot of your names and excited to support your hospitals in this new project.
Great. Thank you so much, LaToya and Francesca. We also want to thank next the team from the California Department of Public Health. And thank you so much, Paco, Sexually Transmitted Disease Control Branch, who are providing subject matter expertise to support technical assistance and evaluation for EDSP. Bridge is really grateful, and I in particular are really grateful for the opportunity to work with these folks at CDPH and benefit from their expertise. So next I'll introduce Dr. Kathleen Dr. Jacobson, who is American Academy of HIV Medicine and HIV Medical Association HIV specialist and board certified family physician with over 30 years experience. Her clinical care experience includes full spectrum primary care, hospitalist and ICU care, as well as emergency room consultations for complex HIV and STI patients. Dr. Jacobson is currently the chief of the STD control branch at California Department of Public Health and is the former chair of the California COVID-19 testing task force. In these roles, Dr. Jacobson has overseen the clinical, scientific, administrative, and budgets for California. She is on the board of directors for the HIV Medical Association, for the Infectious Disease Society of America, and as previous medical director of the Los Angeles region Pacific AIDS Education and Training Center, Dr. Jacobson has extensive experience in workforce development, capacity building, and technical assistance to clinic systems and emergency departments. So I'll pass it over to Dr. Jacobson. Welcome.
Yeah, thank you, Cynthia. And I want to express my gratitude to the Bridge team for everything they've done to make this possible. And also want to welcome all of you for being here today. We're very excited to have you here and very excited to launch this emergency department screening program. For those of you who know me, ED screening, treatment, and linkage to care is near and dear to my heart. And the reason for that is because of all my years as an HIV and STI physician, I've developed a deep appreciation for the critical role that emergency departments play in controlling not just HIV, syphilis, and Hep C epidemics, but frankly, all of the epidemics we have. EDs, in regards to HIV, syphilis, and Hep C, EDs are a safety net for HIV-infected individuals, and it's often their sole and only point of entry into the healthcare system. In the rollout of HIV testing in emergency departments across the U.S., paralleled the decline in those that were undiagnosed. So it paralleled the decline in people who didn't know their diagnosis as HIV testing programs rolled out to emergency departments. And we also know that 24% of pregnant women with syphilis visited an emergency department during their pregnancy. And we've seen positivity rates for syphilis and hepatitis C in emergency departments that range anywhere from 5 to 10%. So please know, all of us are really excited about you being here today, and we have an in-depth understanding and appreciation for what all of you are going to be able to do to help us control these epidemics in California. And with that, I'll turn it over to Ellen.
Wonderful. Thanks so much, Dr. Jacobson, for that welcome. We can move on to the next slide. So to provide some additional background to ground our conversation today, we wanted to first share why this project is focusing on syphilis, HIV, and hepatitis C virus. First off, we know that syphilis and congenital syphilis rates are rising, and California also carries a substantial burden of chronic hepatitis C and HIV, with many people left unaware or untreated. In addition, syphilis and hepatitis C are curable, and HIV treatment can render the infection undetectable or untransmittable. And finally, there's overlap or a syndemic among disproportionately affected populations and transmission dynamics. Next, why is this project focused on emergency department settings? As Dr. Jacobson mentioned, and this audience is already well aware, for those who experience barriers to routine care, emergency departments are often the sole point of contact with the healthcare system. Emergency departments truly reach patients where they are. In fact, several evaluation studies have been published by emergency departments across the country on this topic and have found that emergency department screening programs can result in increased diagnoses of syphilis as well as other asymptomatic STIs. Next, they can reach a population that otherwise may be missed through traditional screening recommendations. And finally, they can potentially avert cases of congenital syphilis. In an evaluation study completed in Miami-Dade County, the emergency department enhanced their routine HIV and hepatitis C opt-out screening infrastructure to include a syphilis smart screening algorithm to identify patients for routine syphilis screening. 6 months post-implementation, the algorithm triggered 4,806 syphilis tests, and 122 patients, or 2.5%, tested positive. Out of those 122 patients, 59 were confirmed positive, and in total, this screening program prevented 9 cases of congenital syphilis. Emergency departments may also play a critical role in reaching individuals with undiagnosed HIV. One driver of HIV transmission is that approximately 1 in 10 people living with HIV in California have not yet been diagnosed. Because patients with HIV visit an emergency department at more than twice the rate of the general population, and emergency departments may serve as the primary source of care for marginalized individuals most at risk for HIV infection, the routine offering of an HIV test in emergency departments can be an effective means to diagnose, link, and re-engage patients in care. In terms of hepatitis C specific studies have found that 11% of emergency department patients in an urban ED in California reported a history of injection drug use, and that undergoing a blood draw did not increase the length of stay. In addition, they found that 10.3% of patients tested hepatitis C antibodies positive, and that half of patients were previously diagnosed with HIV or hepatitis C, but many were out of care. And finally, why opt-out testing? And maybe I'll first start out by sharing a definition of what we mean by opt-out testing. So opt-out testing is when patients are notified that testing will be performed unless they decline. And opt-out testing is recommended as best clinical care by CDC and health departments, regardless of reported risk behaviors. Opt-out testing is also an effective strategy to identify infections, begin immediate treatment, link to care, prevent transmission, and promote health equity. And next, I'll hand it back to Cynthia to give an overview of awardees.
Thank you so much to you, Ellen, and also to Dr. Jacobson. I know that information you shared can be really useful to sites as you all are moving forward and talking to folks within your organization and community. So I'll talk about that in more detail as we move forward. Right now, we're going to transition to an overview of y'all, of the awardees, so that you can get to know a little bit more about each other. And before we do that, I'm just going to take another moment to celebrate that this California state appropriation of funds is the first of its size nationwide. And I also want to note that we had an overwhelming response to the RFA. 73 EDs applied for this highly competitive funding opportunity. And so if each of you in this cohort of 28 funded EDs will help shape this critical and innovative work. So let's look at the cohort. On the next slide, we have a map that will also drop the link into the chat so that you all can look at the live map, hover over the different sites and see the names of your neighbors and your across the state new friends in this journey together. I'll also mention that the EDSP website has the full list for your ongoing reference as well. So the selection process prioritized a health equity approach to reach those most disproportionately impacted by syphilis, HIV, and HCV. And the distribution's emphasis on the Central Valley in particular that you can see here on the map is driven by a focus on preventing congenital syphilis and on earlier identification of HIV infections. So also taking a look at the other side here, we see that the cohort characteristics meet the goal of the state funds. So there's a diversity, both a diversity of low, medium, and high volume EDs in terms of annual ED visits, and the program is represented in both rural and urban settings. So of the 28, you can see that 17 sites received the base award and 11 sites anticipate following up on a high volume of patients with positive test results and received supplemental navigator funding for an additional navigator throughout the course of the funding. So this distribution and this process really echoes the Bridge commitment to treatment, equity, and connection. Routine opt-out screening in the ED reflects Bridge's model by offering testing where people are at and connecting patients to treatment and ongoing care. So next, I'll say that here in the cohort group, we have a rich mix of experiences with and plans to implement, expand, or sustain ED-based routine opt-out screening. So I'm going to pause here. This is for emphasis. I want you all to hear that you all are exactly where you need to be in this moment. And we are here to support and help build your capacity no matter in which one of these you are. So we have sites who are brand new to implementing opt-out screening. We welcome you. We also have many sites who are expanding programs. So for example, there are sites who are currently routinely screening priority populations who will use these funds and support to expand that opt-out to every ED patient who receives a blood draw. And others, of course, will be able to sustain their programs that otherwise may have been at risk of ending. So we really celebrate your varied experiences, ideas, and the questions that come of that. The dynamic nature of our group really opens possibilities for collaboration, for mentorship, and for small group cohorts. So let's talk a little more in detail about kind of current state. This is an overview of current testing practices among the EDSP funded sites. I'll just note the source for this data was your applications. And from left to right, you can see that we have in light purple those sites currently only doing diagnostic testing of symptomatic patients. And then in darker purple, we have those screening priority populations for each infection along the way. And then in that cranberry color, we have sites that are screening all patients who receive a blood draw. And finally, on the far right in orange, those who are doing universal screening. So from this data, we can see that a larger percentage of funded EDs are doing only diagnostic testing and screening of priority populations for syphilis when compared to current testing practices for HIV and HCV. So what this shows us is really that there's a range of where EDSP participants are starting in terms of testing practices for syphilis, HIV, and hepatitis C virus infection. And we see a lot of potential in this for expanding screening reach through EDSP. I will also note before we move on that many sites are already doing or may plan to start ED-based treatment for syphilis, HIV, and/or HCV, which critically increases equity and access and continuity of care. And on top of this work in syphilis, HIV, and HCV, many EDs, I believe 9 EDs expressed interest in the optional funded activities and plan to include routine opt-out screening for chlamydia and gonorrhea through the course of the program. And 1 ED plans to implement Mpox vaccination in their ED as well. So, as I said, we're going to do kind of a recap and program overview. So I want to take some time in the next slide to recenter in the program goals. Paco, when you have a moment, that's great. Thank you so much. So Dr. Jacobson and Ellen both kind of integrated this into the experiences and data that they shared. The program goals are first to identify and immediately treat those at highest risk for syphilis, HIV, and HCV. We also want to help control these epidemics statewide and reduce morbidity and mortality. And we also really want to improve health system capacity. We do this through Bridge's commitment to 24/7 care access and by linking patients to both healthcare and community services. And we want to further health equity and reflect our commitment to addressing the social drivers of health through this work. So what are we expecting of EDs that participate? Hopefully this is a bit familiar at this point. What we're expecting is to implement or sustain or expand an ED opt-out testing program, including treatment, providing patient education, linking patients to follow-up care. And really importantly, the EDSP model roots in a syndemic approach. So that is centered around person-centered and trauma-informed care, racial and social justice, harm reduction, and health equity. And this seeks to address the interaction and overlap among disproportionately affected populations and transmission dynamics. So next up, I'm going to go ahead and pass back to our partners, Ellen and Sophie.
Great, thanks so much, Cynthia. Finally, we wanted to talk about what technical assistance will be available to emergency departments. So throughout the project, there will be 8 webinars or trainings for clinical staff, which will cover key implementation topics from patient navigation to creating processes and protocols. As you can see, the green star shows where we're at today, having this project kickoff call. And then we will be hosting 5 webinars throughout 2024, a webinar on sustaining your program in 2025, and a final project wrap-up webinar at the end of the project in 2026. In addition to formal webinars and trainings, we will also be hosting a monthly emergency department community of practice, as we've heard over and over that having ED to ED conversations is a facilitator to implementation of these types of programs. The emergency department community of practice will serve as an informal space where ED providers can chat with other ED providers across California about best practices, barriers, and potential solutions that they're experiencing, and ways that they can partner with their local health department. And these meetings will be open to both EDSP awardees along with other EDs in California that may be interested in implementing a screening program. We've added all EDSP contacts to this meeting series. And if you haven't gotten the calendar invite, please reach out and let us know. We're happy to add folks to the distribution list. There will also be ongoing coaching, a dedicated patient navigator community Slack channel, and access to a repository of resources to support this work. Feel free to scan the QR code on this slide to begin to take a look at the different resources that are available. And please note that we will continue to add to this repository over the course of the project. And with that, I'm going to hand it over to my colleague, Sophie, to talk about data collection and reporting.
It would be helpful if I unmuted. Today, I'm going to provide you all with a very high level overview of the goals of data collection for EDSP and some metrics that will be calculated. Before I dive into that, I want to provide just a couple key points. The data sharing agreement for this is undergoing final review and will be shared with emergency departments soon. And we're going to be hosting a webinar in January to provide more information on data elements and data collection tools. So stay tuned for more information to come. So as part of this program, EDs are going to be participating in data collection efforts to support two program goals. First, data collected from EDs will support an evaluation of EDSP as a whole. And this evaluation will focus on the process of implementation by outlining best practices, lessons learned, and program models. The outcomes of the program by determining if implementing opt-out testing is an effective strategy to increase testing, identify positive cases, and link positive cases to care and treatment. And an assessment of whether screening in this setting reaches some of the most underserved communities. Second, data collection from EDSPs will support reporting back for ongoing program improvement. These data will be reviewed and analyzed in an ongoing way throughout the program to support, to help you all understand and improve your programs. Some metrics that we plan to calculate to assess outcomes and to support the ongoing program improvement fall into three main buckets. First, testing and diagnosis. Second, treatment in the ED or hospital. And third, linkage to care. We're going to go into the metrics in a lot more detail at the future webinar, but at a high level, for testing, we're going to be collecting data to calculate the number of people tested for and diagnosed with syphilis, HIV, and Hep C. For treatment in the ED or hospital, we're going to be collecting data to understand the extent to which treatment for syphilis, HIV, and or Hep C is provided in the emergency department or hospital setting. For linkage to care, we're going to be collecting data to understand the extent to which linkage to care and or treatment for syphilis, HIV, and Hep C is facilitated by navigators. This will include looking at referral to and linkage to follow-up appointments, attendance of first appointments, and treatment happening outside of the ED encounter. We also aim to look at some reasons why patients aren't linked to care. Finally, we want to understand the extent to which implementation of screening contributes to, if we could go back one slide, thank you, contributes to addressing health inequities by identifying cases in and reaching disproportionately impacted groups who may be at risk for syphilis, congenital syphilis, HIV, perinatal HIV, and hepatitis C, such as Black, Indigenous, and other people of color, people who use drugs, and people experiencing homelessness. So as possible, metrics will be subset by key demographics and social factors such as race, ethnicity, sexual orientation and gender identity, substance use, homelessness, and pregnancy status. Metrics may also be subset by emergency department factors, such as the size of the emergency department or patient volume, and whether it's in a rural or urban setting. And again, I just want to say stay tuned for more information about data collection coming at a webinar in January. And with that, I think am passing it back to Cynthia.
Thanks, Ellen and Sophie. I am actually going to be the one going over our contracts and deliverables reporting. So if you go to the next slide, I will first start with contracts. So exciting, contracts are being sent out right now. Some of you have already received your contract. The rest of you should receive your contract in about 1 to 2 weeks. So be on the lookout from an email from the Public Health Institute. PHI will be the one sending out the contracts. It'll be sent to your primary contact, contracting representative, and authorized signatory that you listed on your EDSP application. If you do have any changes to your contacts, feel free to reach out to the EDSP email and we can change those contacts for you. Once you receive your contract, you will notice that this contract is a fixed price deliverables based contract, which means that once you complete a set of deliverables and submit your invoice, it will be tied to a set amount of payment. We also wanted to note that this contract does not require any financial reporting. We use, again, the deliverables as our way of confirming that you met the requirements to receive payments. So all of the deliverables reports will be submitted through an online form. These will be sent out via email and posted on our website. And that's also where you will be submitting your invoices for each deliverable report. In regards to contracts, if you have any contract related questions, we ask that you email PHI directly, and their contracts and legal team can answer any of your contract questions. Feel free to CC EDSP email so we're aware of those conversations. And then if you have any programmatic questions, me and Cynthia, Latoya are here to answer any of those questions. So feel free to email the EDSP@bridgetreatment.org email, and we can get back to you with those questions. So on the next slide, you'll see a snippet of what the first report is going to look like. So once your agreement is fully executed, you have a agreement execution deliverables report that is due within 2 months. I'll give you a preview that it's a very simple report. We're just asking for confirmation of your contacts and that you either attended today's webinar or you watched the recording of it. Once that's complete, then you actually get 50% of your payment. So that's really exciting. And again, this will be sent to you via email once your agreement is fully executed and posted on our website. On the next slide, you'll see a new section on our website called the EDSP Awardee Hub. So kind of where our RFA was listed on our website, we have a new section for our awardees. This way we can post all resources for you. Specifically in the Awardee Hub, you're going to see deliverables reports, invoice templates, and important dates that are coming up. So feel free to reference this as the project goes on. Then on the next slide, these are the key deliverable report dates. These are all really important, all tied to payments. So I recommend that you keep track of these. We actually just put in the chat the important dates of this project, including all the important webinars, community of practice, and the deliverable reports. So as I stated, you will first have your agreement execution deliverables report due within 2 months of your fully executed agreement. And then after that, the reports are every 6 months. And they go until the end of the project. And then if we go to the next slide, so how each report is going to look starting at the 6-month deliverables report is they're going to be broken up into 2 sections, into your implementation milestones, which have 16 to 18 milestones, depending on if you were receive the base award or the supplemental funding award. And for people who don't have their contract yet, feel free to look at the RFA that was just put in the chat. That lists the implementation milestones that you can reference. And basically the way this works is each 6 months, you're going to be building on these implementation milestones. So at 6 months, you're going to be doing 4, and then so on, you're building on each time. We also don't require them to be in any specific order. So again, recommend you looking at the RFA or your contract to see where your site would like to start on their implementation milestones. Then you'll also see a program participation section on each report, and this will be specific to what's going on in the project. So attending webinars, checking in with your navigator and clinical champion. Again, this is also listed in your contract or in the RFA for reference. And now back to Cynthia.
Okay, great. Thank you so much, Francesca. And I'm just going to pause for a moment so folks have time to get those links and the awesome document that Francesca shared, which is all the important dates chronologically throughout the program. I'll also say, which I might be repeating, that when we send out the recording to all of y'all and to anyone who registered for today, all of the resources that we're sharing will be included. And to also just give another shout out for going on the website and checking things out. There's now a really extensive clinical and other resources list that's all built out there for you. So that can be another great place to start. So that's really what we're talking about next, is the place to start. So we know what to expect about contracts and reporting, and what's to come about data, those deliverables. And let's discuss next who is going to make this all happen. So each of your hospitals has worked in some capacity with Bridge to implement a culture of harm reduction and low barrier MAT in the emergency department. So you, or perhaps your colleagues, are familiar with our model of collaboration and leadership of a clinical champion and patient navigator to lead change in the ED. And we know that no matter how passionate and smart and experienced your clinical champion and navigators are, and I know you all are because I see you here, and we've had the opportunity to work with many of you, they will need to engage a variety of stakeholders and champions. And we know that change management is just not as successful or sustainable with only 1 or 2 people trying to make change. So what we're looking at here is I'm going to focus on the kind of core EDSP team and staffing needed to ensure successful program implementation or expansion. And I will say, you named these folks and other team members in your application, right? So it was the whole thing. It was like name and title and contact and all of it. And the world is a dynamic place and things may have shifted. So now is really the time to revisit who will make up your team. Remember, I'll say this again, it is an allowable use of funds to include staff coverage for those supporting the program. So the clinical champion, this person is an ED provider or physician who has shown interest in patients impacted by STIs, HIV, and HCV. And it is critical that he or she or they are available and willing to drive the project. So available and willing to drive the project. So again, remember, you may use that available funding to really ensure their capacity to implement or expand your program. They will work closely with the patient navigator. Depending on ED size and volume, sites will have 1 or more patient navigators, and these folks engage patients with new positive results to provide education, partner treatment and prevention, and linkage to treatment and supportive services. EDSP patient navigators communicate daily with the local health department and clinics where patients receive follow-up care and follow up with patients until linkage to care is confirmed. So some of your sites may already have peer navigators who are doing other work, perhaps doing substance use disorder related work or other types of projects. Maybe some of those folks are going to split their time and join your EDSP team. I want to acknowledge that some of you may not have ever worked with a patient navigator in your ED before. And so this will be a new part of your implementation. And we've included one of our resources, which is a template for a navigator, an EDSP specifically, navigator job description. So even if you already have an ED navigator, this is probably a helpful tool to look at really what might be expected and how to, what you can communicate to the patient navigator about the expectations and plans for their role. So next we have the lab champion. So perhaps the director or a staff member in the lab who will be the main point of contact to help drive changes, which is primarily to ensure timely turnaround testing of syphilis, HIV, and HCV. In the community of practice that Ellen mentioned, which is our ED to ED peer-to-peer resource, a peer-to-peer sharing discussion group and open forum. For anyone who was able to join yesterday morning, there was a really rich discussion, and there was great talk about the lab champion and what labs can help the team do. Does anyone have any other thoughts on their mind with the lab champion besides timely turnaround of testing? If you could put it in the chat, like what have you worked with your lab champion on already, or what you're thinking about doing that with? I'll give that a moment. So again, the question is, what else are you going to collaborate with your lab champion on? I see some questions in the chat, so we can circle back to those too if we get time, and if not, then we'll make a note of them to follow up with you folks too. A couple other items that the lab champion might help you with are, I really heard yesterday in the community of practice to meet with that person up front and early to anticipate the increased volume and test and positive results. Thanks so much, Tashima. Creating lab orders specific to your routine screening program might be something to partner with them as well. So next we have the data lead. So that person is someone who can pull or guide the pulling of data from the EHR and coordinate all data from different sources for submission. So note that the ED champion and navigators also have a hand in collecting data or supporting data collection. And there should be someone identified for pulling EHR data specifically and coordinating data collection and submission. The clinical champion will meet with these folks as well as stakeholders to build an action plan for your implementation or your program expansion. So stakeholders can be both partners within your ED, within your organization, and within your community. Who are some of the stakeholders that you plan to meet with? So this again is a question for the chat. What are some of the stakeholders who are on your mind besides this core group, or perhaps who you've already worked with in the past? Great, I see some ideas for what to do with the lab champion there. What other stakeholders are in your mind that you'll need to work with? Great, thanks. I'm seeing the local health department to assist with syphilis and other case identification, with syphilis case identification, their local HIV clinic for linkage of care, Department of Public Health, outpatient partners that treat infections. So really starting to build a relationship with them. Great, include other community clinics that provide specialty care too. Great, FQHCs along that same topic. Great. Let's take a look at our next slide. Oh, and I see a specific shout out to those in a rural setting about partnering with local outpatient care providers and expecting to be the only local testing resource. Thanks for that. So who did we miss here? Is there anyone that showed up in the chat that isn't in this kind of beginning of a brainstorm of your stakeholders and champions that you're going to need to talk with? If you look at this graphic here, what's showing on the screen, I'll describe it, is at the center of like a starburst is the clinical champion and the patient navigator, and webbing out from them are various stakeholders and throughout the ED, throughout the organization, and throughout your community resources, which I saw many folks share that are on their mind in the chat as well. One example that was discussed yesterday in community of practice as well, which was mentioned here, was working with IT and EHR partners to build out EHR alerts and algorithm-based automated orders. So that's another example too. I want to mention that stakeholders can become champions of the program. So this may have happened to folks unexpectedly in the past. So you might find that a specific nurse really becomes an advocate and a resource to uplift the program. They're chatting everybody up, they're answering questions among their peer group, they're getting people hyped. So it's really important to think about a brief why, to link people in to knowing why EDSP is so crucial. So perhaps your why will be built to include some of the research and outcomes that Ellen shared earlier, or maybe your own lived experience or your work experience. You will need a quick script to share with stakeholders to draw them into this partnership. And once that conversation is started, then you can hear perhaps they have concerns. You can provide data and start to build relationships to start to build out your program and your action plan. So next, I'm going to ask you all to do a quick brainstorm. We're going to take a couple minutes to do some individual thinking on the questions here. And I want to say before I share the questions that this isn't like a perfect answer moment. This is a generate some useful information kind of internally moment. So also this is not just for clinical staff. I know we have grants administrators here and perhaps hospital leaders. All of you folks need to also engage on EDSP in your organization for its success. And so I ask you to participate as well. So please grab a pen and paper if you have those things still in your life, or maybe the notes feature on your phone or your audio memo, whatever you want. And the first question I'm going to ask you to just take a moment and brainstorm on is, who is the first stakeholder you are going to engage? Remember, this is just for you. So if you're stuck, doesn't have to be the perfect answer. Just write down as many of those stakeholders as you can remember. That's fine. If anyone's inspired or interested, I invite you to share your first stakeholder you're going to engage with in the chat. You're welcome to do that. Great, thanks, Ardenise. Get right started with the clinical champion and see what the next steps are. Awesome, great. Thanks, Carmen. And if you've already met with public health, I think that's fabulous. And I invite you to think of your second stakeholder. I'm seeing first engaged with ED nursing and ED physicians when you started several years ago, that was really the first place to start to develop trust and interest and partnership right there within the ED. Great. Yeah, the IT and the lab to really start to get some of the technical and logistical plans in place. Yeah, I see a comment here to really just start with ED physicians, because if they won't support the program, that's really going to be a barrier and a hindrance. And so that's part of having your why script, right? Like that little snip of data or that little patient story that's going to really start to build support. Okay, thanks everyone. Let's move on to the next question, which is, what is that why that you're going to share with this person? Doesn't have to be right. It can be one sentence. And if you don't have a why yet, what do you need to know to develop one this month? And where can you find that information? So that I'll just give like one place you can find that information is in the resources page on the EDSP website. Again, there's a really pretty rich and exhaustive list that can with resources and tools for you as well. So as we start to wrap up, let's talk about, oh great, I love some folks are sharing their whys. I really appreciate that. Because going upstream is smart medicine in an era of ever expanding resource and capacity constraints. Thank you. To improve public health in a variety of ways. Thank you so much, y'all, for sharing those as well. So as we begin to wrap up, let's talk about your next steps. Paco, on the next slide, we can share with folks, if you've already received your agreement, please review and have the appropriate folks sign it. If it's complete or once it's complete, you can, as Francesca said, you can fill out that first deliverable reports today and send in your invoice. The data sharing agreement will come soon to be reviewed and then submitted to our data partners at CDPH. And we've been planting seeds about this, about working with your team to establish an action plan. Another resource that you have that I just want to remind you of is the list of deliverables. Those can really be moved around and shaped into your action plan. And particularly if this is totally brand new to you, it can be a great place to start. And then to really stay connected, the next community of practice is on January 17th. We ask that you add a recurring calendar reminder for the monthly webinars that are going on this year. They're on that important dates list, and we'll send that in an email as well. The registrations will be available on the website soon. And then to really reach out to us at Bridge as needed. So let me show you how to do that. Oh, thanks, folks are still continuing to share their whys in the chat. I'm so appreciative. So before I end off with all of our contact information, we would love to get your feedback on today, on the webinar, and to use that to shape the program moving forward. So on the next slide, there's a QR code, and we'll drop the link in the chat as well. We'd appreciate you taking a few minutes to fill that out. And then our contact information is at EDSP@bridgetotreatment.org. So this is where you can reach us for questions that come up after today or that came up today that we didn't have capacity to go through in detail with you today. Please submit them there so we can follow up with you. We really look forward to hearing from you and really look forward to being on this journey with you. So I want to thank everyone so much, and we look forward to talking with you and seeing you soon and growing together. Thanks, everyone.